Everybody of you knows it already. And just a moment, please. Yes. So the drainage and ethanol injection of multiple very large hydatid liver cysts. You already have seen a couple of cases from Dr. Zeren, and this will remember to you the more accepted classification of hydatid liver cysts is type 1, 2, 3, 4, 5, and 6. That type 1 is an unilocular simple cyst, less than 4 centimeters in size. It is usually not fertile, but fertility may increase with size, and usually there is no sand, no ecogenic material inside. The type 2 is unilocular, round or oval, over 4 centimeters and sometimes over 15 and 20 centimeters. Is very fertile, is probably the more dangerous hydatid cyst that we can meet in the liver. And the diagnosis in absence of material inside and in absence of detachment of the inner membrane is very difficult. This is usually the aspect that you can encounter. Type 3 is a multivesicular, multiseptated, sometimes wheel-like appearance with other cysts or a non-ecumb aspect inside. Is usually fertile, and the diagnosis is very easy because it's pathognomonic unless a septated abscess or a septated cyst can be suspected. And type 4 is usually a cyst in which there is a almost complete detachment, detachment of the inner membrane with the so-called water lily sign or nymphea sign. There may be some daughter cysts, but usually they are not present. It usually is not very viable, this cyst. The organized cyst, the ecogenic, is the type 5, and the calcified is the type 6. This classification point out the viability of the cyst. It is very, very well done, so that from type first to type 3 we have the most viable cysts. Type 4 is still viable but less than the other type. These two last type are usually not viable, so that they must just follow up and don't need any treatment. The treatment for hydatid liver cysts is surgery, but is a high cost. Lack of surgical facilities in the areas where there is much more prevalence and incidence of this disease, and also there are many cases of relapse and recurrence of the cyst in patients that have been operated on. Albendazole is a useful and it's rather it's not cheap therapy, but it's not really very effective. It should be continued all lifelong of the patient. The percutaneous approach by percutaneous aspiration and injection of ethanol or other scoliocidal agents is a therapy that is already been accepted from the World Health Organization as the first choice in the emerging countries. In Western countries, still the surgery is considered the first therapy of choice, but where there is no enough surgical facilities, where it's difficult to have an operatory room efficient for this kind of operation, the first choice is the PAIR. Now, percutaneous treatment of very large, over 6 cm hydatid liver cysts with ethanol injection is considered unsafe and somewhat ineffective. We present the result of a 6-year experience with treatment by aspiration and injection of ethanol of a series of patients with multiple and very large hydatid liver cysts. Between June 2004 and January 2011, we treated 9 patients with 18 large hydatid liver cysts between 6 and 15 centimeters with a mean size of 8.5. The patient had one patient had 5 cysts, 4 patients had 2 cysts, and 5 patients had 1 cyst. 13 cysts were unilocular, 5 cysts were septated or multivesiculated, 7 patients were treated percutaneously, and 2 under laparotomy. Follow-up was performed by ultrasound every 3 months and abdominal CT every 12 months. Everybody knows and this morning we learned that the ethanol is very cheap, the needle for treating and the catheter for treating this kind of disease percutaneously under local anesthesia or only sedation are very cheap approach. That's why in developing countries where the prevalence of this disease is very high, is accepted as the first choice treatment. This is the case of a female, 38 years old, asymptomatic. They had 2 giant cysts, 15 and 14 centimeters in size. She was treated by the catheter procedure by Seldinger technique, and this is the pre-treatment aspect. This post-treatment aspect, there is a subsequent control that showed a shrinkage inside. The patient had no recurrence, no relapse in the abdomen, neither in the chest, and she is still well. As the result is a follow-up range of 64 months with a mean of 36 months, but now the follow-up is longer. This is updated at 1 year ago. No minor complication was reported. At last US examination during the follow-up showed a solid pattern and in 11 out of 18 cysts and a fluid mixed pattern in 7 cysts. A substantial shrinkage was observed in no cysts with decreasing size ranging from 30 to 80% of the treatment volume. In no patient, lung recurrence and chest X-ray or abdominal spreading of the disease at CT was reported. A dramatic decrease of antibody anti-anticoagulant dose in 5 patients was observed. This is the case of a female, 27 years old. Now actually she is 32 years old, and she presented with a very, very hard palpation liver that clinically was highly suspected for a multimetastatic liver. But when studied with US, we could see 5 large cysts that compressed the remnant, the residual liver parenchyma against the abdominal wall, and that's why it seemed so hard, like wood. And this is before the treatment, and this is post-treatment. This is just 1 year post-treatment aspect at at the CT. The patient was treated in 2 sessions. In one session, 3 cysts were treated. In the second session, both the sessions were performed in local anesthesia. And this is the results at US follow-up. You can see all the cysts are completely organized, type 5, and not more viable. Here you can see very well the liver parenchyma recovered from the pressure that was present before, and we can see 4 cysts in a single scan here, and the other cyst that is a little cephalic compared with the other 4. This 74 months, but the patient very recently came for the follow-up control. She's very well. This is another patient with 2 cysts. This is the treatment, and this is the residual solid pattern in one cyst and mixed part in the other cyst as a follow-up. This is a cyst that is a recurrence after surgery. This patient had a left lobectomy because of a hydatid cyst. This is the cyst which after the puncture, there is the detachment of the inner membrane. Here the injection ethanol, this is the residual at this is 18 months. This is a type 4 cyst treated, type 3rd cyst treated by puncture of all the daughter cysts inside the main cyst. That is the residual solid pattern at follow-up. This is a multi-loculated cyst. All the daughter cysts were treated by aspiration and injection of ethanol, here, and so on. And this is the residual solid pattern at follow-up. This is a very large multi-loculated cyst, was treated by injection of ethanol and aspiration. All the visible daughter cysts, actually there was a shrinkage in the first, at the first follow-up. In the first 2 years, some daughter cysts reappeared inside the cyst during the follow-up, have been treated again other 2 times, and the patient is now still in follow-up. Probably this kind of cyst is too difficult to treat by this procedure, and probably other procedure could be useful. Someone is trying microwave or RF, and we are thinking to treat this patient by insertion of microwave to cook also the daughter cyst that we can see at the ultrasound. In conclusion, our experience open and percutaneous aspiration and ethanol injection of very large hydatid liver cysts can be safely performed and show a high long-term efficacy. Thank you.
Any question?
How many cycles of albendazole therapy you perform?
We start 1 month or 15, also 2 weeks before the treatment, and usually we in local cysts we stop the treatment 1 month later when it seems that the cyst is completely cured. In the multiloculated, the patient that relapsed with daughter cyst, she have several courses and still is having several courses with stopping the therapy for 6 months and doing the therapy for 3 months when it seems there is no daughter cyst inside. When another daughter cyst appears, we treat the patient for 3 months, we follow her, and sometimes we really can realize that the drug is effective because we could see a shrinkage or even a disappearance of the daughter cyst, but never, don't think that the treatment can exclude, can cure definitely the patient, since even if we continue the treatment for 6 months, at the withdrawal of the treatment, we had again new daughter cysts inside. So, and is not indicated at the moment the lifelong treatment of this patient, but just courses separated from suspension of the therapy.
Short question. Are you anywhere treated echinococcal cyst type 4? That was alive.
Of course, we always aspirate and send for viability of protoscolysis inside by Rosso Congo, by blue or methylene for seeing the viability, and not in this series, but in previous series, actually the total is about 85 cysts that we have treated in total, and in the previous series we punctuated a couple of, I don't remember the exact number of the water lily sign cysts, and they were viable. We could find viable scoliosis inside, but even if in the classification that cyst is indicated as probably non-viable, but only probably, so we are in agreement with what the classification indicates.
Thank you very much.
Did you have any serious allergic reaction?
Yeah. Unfortunately, I had a very serious and a fatal anaphylactic shock, and it was 12 or 13 years ago, with the patient number 65. I can remember very well that we had no side effect until that patient, not even minor allergic reaction, and we start really thinking that it was a very safe approach. But I was in, if you think that the first treatment were performed in the diagnostic room, but in that case I was in the operatory room, in local anesthesia. It was it's really anecdotal, and it's a strange fact. The patient was the father of a surgeon that 1 month before lost a patient, operating him surgically for a hydatid cyst. So that he decided to cure his father by percutaneous approach. We performed it. He had this anaphylactic shock, and he worsened very fast. We also tried intracardial adrenaline, everything, but it was useless, and the patient died. And it was a very bad experience, but that teaches us that it can seem a very safe approach, but you must put in your possibilities that something like this can happen to the surgeon, can happen also by this mini-invasive approach. Other complication, not in this series, but in the previous patient, is the infection of the cyst that happened in 2 cases of unilocular large cysts, but I must say that that's rather than a complication, could be considered a good thing. So I'm not suggesting to put bacteria inside the catheter, but I must see that the patient, both patient had probably because of the infection, a restitutional integrum of the liver with complete disappearance of the lesion.
So we should use bacteria.
Maybe in the future, unless the ethanol, we could use a low pathogen strength bacteria for cure biological therapy.
Yes, medically modified. So there are no more dogs.
No,
Now that's the discussion
yes.
from you. Okay.
We have the presentation from the